So welcome all to a special webinar conversation on a vital topic in this year for NCD Action, increasing access to inhaled medicines for COPD and asthma. Our hosts today are the Forum of International Respiratory Societies, or FIRS, the NCD Alliance, the NCD Policy Lab, and the World Health Organization. I'm Leith Greenslade, coordinator of the Every Breath Counts Coalition, and delighted to be your moderator today. For the next 90 minutes, you will hear from world experts on COPD and asthma, as well as from leaders of the broader NCD movement and critically from patients and their families. Our purpose is to do more than raise awareness about a neglected issue that is affecting hundreds of millions of people. It's to persuade you to become advocates using new campaign tools that have been created by FIRS and will be presented today. Throughout our conversation, we encourage you to post comments in the chat as we go. We are recording and the video will be available on YouTube later today. And now it's my pleasure to introduce our first speakers who will give opening remarks that set the scene for our discussion today. Professor Guy Marks, President of the International Union Against Tuberculosis and Lung Disease and also President of FIRS, and Professor Alvaro Cruz, who is a member of the Board of Directors of the Global Initiative for Asthma, otherwise known as GINA. Professor Marks.
Thank you, Liz. I'm just going to share my screen. Right. Is it visible?
Yes.
Good, thank you. Well, thank you, Liz, for introducing me, and welcome to the attendees at this important webinar. My task is a brief one and forms an introduction. And the title for my talk is "Why Do We Need Action on Access to Inhaled Medicines for COPD and Asthma?" And in a nutshell, there are three words that describe why we need action. One is impact, the other is justice, and the third is equity. These are the three themes that underpin the need for action to improve access to inhaled medicines for people with chronic respiratory disease. So I notice in the audience there are many people who know very much why we focus on respiratory illness, but I feel that there may be some people who are not convinced. And so I want to have this one slide where I talk about what are the major reasons that we need to focus on respiratory disease. The first is that it's a very common problem, and you're going to hear from other speakers about various measures of the burden of chronic respiratory disease. But the one I wanted to focus on is that from studies, in fact, from the 1990s, we know that it is one of the main reasons that people, particularly in low and middle income countries, but in fact in all countries, seek care at a primary healthcare, in a primary healthcare setting from their local doctor. One of the main reasons, about a third of all presentations are with respiratory symptoms. It's a leading preventable cause of death, particularly in low and middle income countries, and you'll hear some specific data about that shortly. It has a disproportionate impact on people living in low and middle income countries compared to those living in higher income countries. And that's where the equity and justice comes in. There is a considerable inequity at present. COPD is, in fact, potentially preventable. Two particularly important causes, tobacco smoking and childhood infections, underpin a lot of adult COPD, but it's not curable, and hence it has a very large burden because of the burden of these precursors. Asthma is, in fact, not preventable or curable with what we know at present, but it can be very effectively treated and controlled. There are simple, cheap, and highly effective treatments available that prevent severe attacks and deaths in adults and children. And the lack of access to these medicines, which are principally inhaled medicines for people with asthma and COPD, is associated with severe health consequences, hospitalizations, deaths, and costs, and is associated, as I've already alluded to, with massive global inequity and injustice. The overarching goal of the interventions that we're proposing is to prevent disability and premature death due to lung disease. For people with asthma, we've had treatment available for about 50 years, effective treatment available for asthma, usually based mainly around the use of inhaled corticosteroid medications, usually taken twice daily, and these are often being used with a short-acting, rapid-onset bronchodilator, albuterol or salbutamol are the common ones, and they're taken as required for the relief of symptoms. And with this, we saw a profound reduction in the risk of severe attacks, hospitalizations, and deaths, both in clinical trials and, in fact, in population studies. And as I say, these have been known about for over 50 years and in guidelines for over 40 years. More recently, there has been a newer approach developed, which has several advantages over this long-standing approach, still centered on the use of inhaled corticosteroids, but now using just one inhaler, not two separate inhalers, and using that inhaler just as required for symptoms. The way, in fact, most patients want to use their inhaler. They want to take it when they feel symptomatic and not when they don't. So we now have this combination of an inhaled corticosteroid and a rapid onset long-acting bronchodilator called formoterol. And the combination of these, when used, is as effective as this old regimen in preventing attacks. But it only requires one inhaler and it's very easy for patients to use. Moving on to COPD, there are potentially modifiable risk factors, as I mentioned, for preventing COPD, things to do with maternal nutrition, maternal smoking, infections in early life and throughout life, and tobacco smoke. Tuberculosis also can lead to chronic lung disease. Active smoking during life is the most significant cause for COPD, and occupational exposure to dust and fumes. So a lot of work can be done in trying to prevent COPD with all of these mechanisms, but the reality is that there is a lot of COPD already present and is going to be present for decades. These people need treatment, and the treatment is generally a long-acting form of bronchodilator. Again, inhaled bronchodilators, sometimes two different classes, and these improve symptoms, improve exercise capacity, and improve quality of life. To complete the picture, there are non-pharmacological interventions also for people with COPD, prevention of viral respiratory infections, and exercise-based pulmonary rehabilitation, and long-term home oxygen for a selected group of people, which can be beneficial. So just to come back to my first slide, that we need these medicines, generally inhaled medicines of the types that I've just been describing to you, accessible to all patients with asthma and COPD, and we need it and if we have it, we will achieve substantial impact on health outcomes, and we will improve justice and health equity. So I'll finish there and hand over to Alvaro.
Thanks, Professor Marks. Professor Cruz, we welcome you to the stage. Professor Cruz, are you able to share your screen? Can you hear us? So Alvaro Cruz, are you able to hear us? All right. There may be connection issues with Professor Cruz. So what we're going to do is move to our next speaker, and we may come back to Professor Cruz if we can maintain connectivity. So I'm going to invite Professor David Halpin to the stage. Professor Halpin is a member of the Board of Directors of the Global Initiative for Chronic Obstructive Lung Disease, or GOLD, and a driving force in FIRS. Professor Halpin, over to you.
Thank you very much, Leith. So Guy has already set the scene for some of this work. I was asked just to focus a little bit on the cost of the lack of access to inhaled medicines for adults living with COPD. And building on what Guy has already said, I just wanted to explain a little bit about COPD, because I'm aware that in the audience there are many people who know a lot about COPD, but surprisingly there's quite a lot of people in the world who know nothing about COPD at all. So COPD is chronic obstructive pulmonary disease. It's a chronic lung disease. In other words, it's a long-term condition. And the key features are that there's narrowing of the airways, there's damage to the lung tissue, to the alveoli itself, and there's often increased sputum production, the so-called chronic bronchitis. And it's generally a disease that begins to show symptoms around the age of 50, although often it's been developing for many years before that. The principal symptoms are breathlessness, cough, sputum production, fatigue, intermittent flare-ups of the disease, and death. And many people sadly die of their COPD. Guy has talked a little bit about risk factors. So depending on where you live in the world and what you're breathing in, COPD may be caused by tobacco, and that's predominant in Europe and North America. It may be caused by occupational exposures. It may be related to poor development of the lungs that results from childhood infections, maternal smoking, maternal malnutrition. And in many parts of the world, COPD is caused by indoor air pollution, by cooking or heating using fuels that generate smoke within the home environment. And COPD is the third commonest cause of death worldwide. Many clinicians are not aware of that, many policymakers are not aware of that, and many politicians are not aware of that fact. And as I said, many will never have heard of COPD, despite it being the third commonest cause of death worldwide. And that is something we really do need to work to change. The human cost of COPD is high and rising. Nearly 400 million people worldwide have COPD, and nearly 4 million die every year. As Guy said, prevention is essential, but the people that already have COPD will continue to suffer from the disease, and there'll be many millions more who will go on to develop the symptoms who've already been exposed to the factors that cause it. It's somewhat sobering that every 10 seconds, one person dies from COPD. And the burden is predicted to grow as a result of changing epidemiology, of the increased life expectancy in many low and middle income countries. People will live long enough to develop their COPD and to die from it. And it's projected that the number of deaths will nearly double by the year 2050. And the vast majority of these deaths occur in low and middle income countries. It's a tsunami of disease that they are just not ready to cope with. The human cost is one thing, the financial cost is another. And I think when we try and engage policymakers, although the human cost is important, thinking about the financial costs and why it's worth investing in doing something about this disease is also really important. The current global cost of COPD, when you put together the direct healthcare costs and the indirect costs as a result of lost work, lost productivity, is something like $1.3 trillion, which is a huge amount of money. And that will only get worse. Over the next 25 years, that's projected to increase to $1.39 trillion. And if you look at the map, you'll see that most of the increase is in Asia and the Pacific, Southeast Asia. And this projection didn't include Africa, where there is likely to be an even bigger impact of the disease, as I've said already, as other causes of death, infectious diseases, are eliminated or reduced, and as life expectancy increases, the financial cost of coping with COPD will be huge. But unfortunately, we don't have any data on that at the moment. So what could access to inhaled therapy achieve? Well, it could improve symptoms, breathlessness, let people do more, lead to better quality of life, reduce the risk of these flare-ups and the treatment that's required for those flare-ups, which carries side effects itself, reduce the risk of hospitalization, and ultimately reduce the risk of dying. And all of that together means that people are more able to self-care, more able to live independently, from an economic perspective, more able to continue working. I said at the start that the average age of onset of symptoms is in the 50s. So many people have 15 or 20 years of expected work life left, perhaps even more in some countries. Many of them are not going to be able to work because of their COPD, but if we can treat it more effectively, they can continue to contribute to the workforce. And they will be less dependent on others. There's less need for care in the community, less need for hospital beds to look after them. But we know that current access to therapy is very poor. This is some data that was collected a couple of years ago now in low and middle income countries, looking at the availability of the key therapies both for asthma and COPD. And the graph on the right focuses on just one of the main treatments for COPD, one of the long-acting bronchodilators that Guy mentioned. And you can see that in the vast majority of LMICs, it's either not available at all in the orange, or if it is available, it's unaffordable. It costs many days of wages, up to a month of wages for a single inhaler. We've got to do something to change that, and that is what the campaign that FIRS has been leading is based on. So what could better access to therapy achieve? Well, we've said already, it can improve symptoms and quality of life. It can lead to better exercise capacity for both activities within the home, homemaking, looking after families, cooking, etc., recreational things, but importantly, occupational. It could lead to fewer exacerbations and less requirement for oral steroids. And this is a slight paradox. Whilst we're calling for better access to inhaled therapy, what we want to do is to reduce reliance on acute therapies that are used to treat flare-ups that carry significant side effects and focus more on preventative treatments to keep people healthy. We want to achieve less hospitalizations, reduce the risk of death, and reduce the costs of the disease. Now, this is my opinion based on all the evidence in the literature, but it's important to think from a patient perspective about what access to therapy actually means. And we have an interview here in Nepal with a patient who's recently been started on an inhaler for COPD. So fingers crossed, I hope you'll be able to hear this.
नमस्ते तपाईलाई दम भएको कति भयो छ 7 वर्ष यो औषधि तानी राख्नु भएको छ यो अहिले दमको औषधि अनि तान्दाखेरि सजिलो भएको छ सजिलो छ अनि कहिलेकाहीँ नतान्दा गाह्रो हुन्छ
अहिले चटार पर्यो भने नत्र हिँड्दाखेरि चटार पर्यो भने नत्र भने आइले
ए ल ठीक छ तपाईको नाम भन्नुस् त उहाँको छोरा हैन औषधि लिँदा सजिलै छ आमालाई
सजिलो छ यहाँ चाहिँ धेरै इम्प्रुभ भएको छ अहिले धेरै राम्रो भएको छ
So we want to ensure that patients like that have access to the inhalers that will keep them healthy. So thank you very much. I'll stop sharing now.
Thank you very much, Professor Halpin. And I think we have maintained connectivity with Professor Alvaro Cruz. I'll just remind you, he's a member of the Board of Directors of the Global Initiative for Asthma, otherwise known as GINA. Professor Cruz, over to you.
Hello, everyone. I am delighted to be here with David, Guy, and all distinguished leaders that are speakers and in the audience. Let me share my screen with you. I'm sorry for the connection problems. I hope you can see it well now. Well, these are figures on asthma. Over 260 million people with asthma, 1,000 deaths daily, and most of them are premature and preventable. This illustration expresses what many patients with asthma tell us, and they suffer a lot. It's not just the numbers. This figure expresses the torture many people feel by recurrent suffocation. Well, I'm very pleased to join representing GINA this effort of FIRS and its allies, its members, and WHO to make inhaled treatments accessible for all for the reasons that were clearly presented by Guy and David. I'm going to talk about building momentum for action, and I'll bring some of my experience on this. I divided this presentation in four major topics: the need, the know-do gap, which is the gap between what is known and what is done with an example for my region, the feasibility of interventions that I'll bring an example, and leadership and priority, which I think is crucial. I think we are at a very important moment, a landmark situation in which we have leadership, we have priority, we have synergy, and we have some action. Well, this is a review paper. I see Kevin is here in the audience that highlights the fact that 96% of asthma deaths are in low and middle income countries, and we have several problems. One of them, perhaps the major, is the limited access to inhaled corticosteroids. Guy has stressed this, but this is necessary, but it's not sufficient. For instance, in my country, Brazil, a middle-income country, we have free access, but we still have the problem because the patients don't use them. The primary healthcare teams don't know well how to deal with this. Well, these are other estimates of the Global Asthma Network, highlighting that 1 in 10 children have symptoms of asthma. Half of them are inadequately controlled, and many of them have no access to essential asthma medications in the world, and it cannot continue like this. This is the example I mentioned to you. I will bring. This is a program that we developed here in Salvador, a city of 2.5 million inhabitants where I live and work. And we developed this program to offer free treatment with a combination of a long-acting and rapid-acting bronchodilator and inhaled corticosteroids 20 years ago. And as you see here on the right, as we enrolled people and offered free medication, there was a quick decline in hospitalizations in the entire city. This was not a public-led initiative, a public health-led initiative. It was an academic initiative with postgraduate students that established 4 reference centers, and it worked. I couldn't expect it worked so well. Medication was provided by the government, yes, but not the integrated care that we provided. And on top of this, we also noticed later on a reduction in mortality by 27%, and we calculated health economics. There was savings for the families and for the health system. Now, a brief historical note. In 2006, many leaders in the respiratory field developed the Global Alliance Against Chronic Respiratory Disease. This was one of the major meetings we had, and I wish to call your attention to two of the major leaders in this field working from that time, still active till to 2025. They are Arzu Yargansioglu, who is the chair of GINA and has been the chair of GARD for a long time, and Professor Eric Bateman from South Africa, who I have the sour honor to substitute here. He's not present in our world, he's only in our mind and his legacy. He was a major leader of this campaign, and I'm glad that it's working so well. Now, getting close to the end, I wish to bring you a note on this publication in which several interviews were published, and I made a point on what I consider to be a neglect about asthma. It's a culture of neglect. And of course, it's not intentional, it's unintentional, but it's there. Well, what is it? Asthma is always on the bottom of the list of priorities for non-communicable disease. And also, when someone deals with respiratory disease, it's in low and middle income countries, the priority is always for the communicable disease, not the non-communicable disease. So it's always in the last of the list. This is the culture of neglect, and it happens to families, to patients, health professionals. It's not only about policymakers. I wish to finish now expressing how glad I am to see this lung health resolution adopted by the 78th World Health Assembly 2025 that proposes promoting and prioritizing an integrated lung health approach, including asthma, COPD, lung cancer, and the communicable disease and their risk factors. So I think this is a very special moment, and it was created by the need, by the gap in knowledge, knowledge translation into policies, and this unacceptable dissociation between communicable and non-communicable disease affecting the lungs. And this was achieved by a very competent and determined advocacy by FIRS, its members, its allies, and the vision of WHO leadership for improved integrated respiratory health, leaving no one behind. So leadership, priority, synergy, and action. Thank you for your attention.
Thank you, Professor Cruz. Our next speaker is Professor Refilo Masekela. She wears many hats. She's a pediatric pulmonologist based in South Africa. Today, she's representing the Global Asthma Network and FIRS. Professor Masekela. Now, Professor Masekela is dialing in from Uganda, and I don't actually see her in the chat unless she's dialing in on another Zoom line. So, Professor Masekela, if you're with us. Otherwise, Professor Cruz, I'm going to ask you to turn your video off, and we'll move to the next stage of the program and hope that we can engage Professor Masekela. But you've just heard a lot about all of the challenges and the problems. We want to pivot now to some solutions, and we have three distinguished speakers. First of all, Professor Heather Zar, who's a member of the FIRS Working Group on increasing access to inhaled medicines, the group behind the campaign you're about to see. After Heather speaks, we will move to Marina Giacchino from the NCD Policy Lab. Marina is going to talk about how the lab is increasing access to diabetes medicines and what we can learn from that about increasing access to inhaled medicines. And finally, we're very happy to have Leslie Ray Farrat, the new president of the NCD Alliance, who's going to lay out the big picture for us and how we can all play a part in this milestone year for NCD action. But first, a special pleasure to hand over to Professor Heather Czar.
Good morning, good afternoon, friends and colleagues. Let me try and share my screen. I think you can see it. Great pleasure to be part of this very important webinar and to be able to speak to you today on what FIRS is doing to increase awareness and increase access to inhaled medicines for COPD and asthma. So you've heard about COPD and asthma, you've heard about the burden. Why do we need urgent action on inhalers now? If you look at the global NCD action target of a 25% reduction in the probability of dying between 30 to 70 years from an NCD between 2013 and 2025, you will see that things have barely changed. The deep green is the actual probability of dying, and you see the light green and the purple are the global NCD action plan target and the STG target 3.4 of a 1/3 reduction in probability of dying between 30 and 70 years from an NCD between 2015 and 2030. So we are not on track at all to reduce mortality from any one of the major 4 NCDs, despite these 2 global goals. And in fact, only 19, just under 10% of 194 countries are on track to meet SDG target 3.4. So we have a lot of work to do to get there. So FIRS, recognizing the urgency and the importance of this, and also the fact that we have effective inhalers, established a core group. I was privileged to be part of this, led by Guy Marks, David Halpin. You've heard about Eric Bateman's role, who unfortunately passed away. And most recently, Leith joined us and is a dynamo helping us with the many, many activities that the group is currently doing. Initially, we focused on developing a World Health Assembly draft resolution to WHO for global access to these inhalers. And alongside this, we engaged with WHO, with ministers of health, with the NCD Alliance, patient advocates, civil society, many other stakeholders. And as a WHO integrated lung health resolution was being proposed, we joined forces to include some wording on access to safe, effective, and quality medications. And you see, and you've heard about this WHO integrated lung health resolution, which was passed in May. The resolution calls on member states to improve access to and affordability and availability of safe, effective, and quality medicines, vaccines, and health technologies. So clearly inhalers and spaces fit here. And David Halpin was instrumental in addressing the recent UN meeting on NCDs. In fact, he was the only person to speak on chronic respiratory disease as a important NCD. And here you see him addressing the UN only on this, most recently on the 2nd of May. This was very well received. And then the World Health Assembly resolution was accepted. And as Alvaro has highlighted, this is really a turning point for lung health. And FIRS issued a statement welcoming this and welcoming the recognition of the huge and largely unrecognized global burden of lung disease that, as Guy has spoken to, disproportionately affects those in disadvantaged populations. FIRS also launched a new campaign on World Asthma Day last month, calling on governments, industry, global health agencies, and donors to invest greater resources to increase access to inhaled medicines for COPD and asthma by addressing 5 priority areas. Here you see the media statement. All of these are available online and I'll refer you to the sorry, I thought I'd switched my phone off. There we go. I'll refer you to the website where these are obtainable. And the 5 areas in which we think that action is needed are 5 Ps. Policy, we need inclusion of the latest evidence-based inhalers in all global, national, regional COPD and asthma treatment guidelines, in essential medicine lists, and in universal healthcare reimbursement lists. You will know that the WHO PEN guidelines are currently being revised, and that's great news. WHO has heard this and is revising guidelines. In terms of the product, we need improved availability of recommended inhaled medications by facilitating registration, technology transfer, voluntary license agreements, and participation in the WHO pre-qualification program, and mechanisms to make good, effective inhalers affordable. That brings me to price, where we will really need to advocate for reductions in inhaler prices using bulk purchasing, pooled procurement, tiered pricing, generic alternatives, other proven strategies. There are many examples of this. A focus on primary care, as Guy also mentioned. The bulk of people who suffer asthma or COPD are seen in primary care, and we need to strengthen training for primary healthcare providers to diagnose and manage people with asthma and COPD, including access to improved testing and, of course, access to improved treatment. And lastly, patient advocacy, I think really a very key activity that often drives the success of such campaigns. Increased community awareness of asthma and COPD, destigmatizing the condition, and improving the use of inhalers with spacers driven by the people who really understand the illness. And we saw how well this worked for HIV and access to antiretrovirals, and the same should occur for those who have asthma or COPD, and for children, of course, their caregivers, their families. So fortunately, we've seen a lot of momentum since the first high-level UN meeting on the prevention and control of NCDs in 2011. You see the graphic here of how momentum has been building, and we are building up to the 4th UN meeting, high-level meeting, which is in September 2025 in New York. And FIRS is working very hard with the NCD Alliance to ensure the inclusion of access to inhaled medicines in the political declaration. And here you see the proposed wording. FIRS is proposing a revision of clause 35. You see the wording there: to prevent and treat asthma and COPD by scaling up effective, affordable, and effective treatments, including quality, affordable, and effective inhaled medicines, bronchodilators, corticosteroids, and combinations of these. Unfortunately, the original wording included oral steroids. FIRS, the NCD Alliance, Ministries of Health, WHO, others have been working very hard to ensure that this revised wording is what comes to the UN 4th high-level meeting in September, and we're hoping that this is what it will be. I've shown you some of the activities. I've shown you some of the materials. You can access all of these on the campaign toolkit. There's the website. You see their policy briefings and statements. Here are the what's under that tab. There's the policy brief. There's the global slide deck on access. There's the UN multi-stakeholder hearing statement and David Halpin's UN address. And there's the first statement on the World Health Assembly resolution. And then there's also social media aspects where you can find social media statements such as this that can be put out through networks. For example, this one says, now is the time to advance access to safe, affordable, and effective inhalers for all patients with just 5 years left to achieve the SDGs, and with the 4th UN meeting imminent. And here's another one which speaks to the burden of COPD and asthma in terms of deaths and shows graphically where these occur. You heard Emmy earlier talks about the maldistribution, inequity, the high burden in low middle income countries, and the lack of access to affordable, effective medications in these areas, not only because the medications are not there, but because the programs are there and because they are unaffordable. And so these social media messages try to drive change and to move the agenda for equitable access forward. So please join us. The initiative has been led by the FERS working group, which I've spoken to. There are emails. Leith Greenside should also be on this list. I apologize, I don't know how that fell off. And any of us are very happy to share with you any information that you require. Most of the information is on the website, as I've shown you. And I'd just like to close by also acknowledging the leadership and support of the late Professor Eric Bateman, who was really a driving force, not only in this working group, but in lung health globally. Thank you.
Thank you, Professor Zah. And I put a link into the chat to the FERS campaign website. This is managed by Fiona Salter. Fiona is with us today from FERS. It's a beautiful site, and we will keep updating it with new materials. So please click on that link. That's where the slides will also be later today. So we are having trouble connecting with Professor Masekela. She's in Uganda. So what I'm proposing is we spend the next 10 minutes picking up some of the questions in the chat and comments. There's a very important one from Ngozi Ibe, and I wanted to ask some of our experts to respond. So there's a strong focus on strengthening primary care, but Ngozi's comment is that's important, but what's really required in low middle income countries is a specialized medical profession on these issues. Would one of our speakers like to comment on this? And perhaps Guy will invite you to give first comment, and then someone else. We can only have time for maybe 2 responses. But Professor Marks, the issue of primary care versus specialized care.
Yeah, I'm sorry. That's a good question, and I, like most of the other speakers on this call, am a specialist physician, a respiratory physician, and I'm very aware of the important role that we play in managing people with severe and complex lung disease. However, I've also become aware that much of the gain that there is in the management of asthma and COPD can be achieved because it's such a common condition. There is no way that specialist doctors can see all of those patients. And furthermore, there is no real necessity for specialist doctors to see the great majority of patients with asthma and COPD. The management is not necessarily particularly complex. And what we need to do is to try and make that management accessible to as many people who need it as possible, while maintaining adequate referral pathways from primary care to specialist care for patients who have more complex problems, who don't respond to the usual treatment, or who have side effects, for example, from the usual treatment. There are, of course, many patients who are difficult to manage, and that's where we need adequate referral pathways. So I'll stop there, and I see a few other comments about this. I think Heather, you had something to say. Mm-hmm.
Yeah. So I think this is also a really important point. And I just think I would like to say I don't see them as mutually exclusive. I think specialists and people working in hospitals have got a big role to play in education, in strengthening primary healthcare processes and training, and also in inputting guidelines and adapting guidelines for local use. So I think ideally, a close partnership with primary care providers and with secondary or tertiary level healthcare workers is actually essential because it's a system. And I see a good tertiary or secondary care specialist as really supporting and strengthening primary healthcare. Thank you.
Thank you. And a last comment, Professor Cruz.
Well, I think this is a very important matter, and I wish to reinforce what Guy and Peter have said and add another comment. During my presentation, I mentioned that inhaled medications are necessary but are not sufficient. The issue is that different from other non-communicable disease, the diagnosis of asthma and COPD require measurements that are not easily available in primary health care. It requires medication by inhalation that are not a single pill that people just swallow. So there are some tricky issues about diagnosis and treatment. But of course, this all can be conducted in primary health care. It only requires priority. That's the issue. If you leave chronic respiratory disease at the bottom of the priority list, these issues that are specific, the issues on diagnosis, the issues on treatment with inhalers will not be solved. So we need understanding of these things to build capacity for primary health care to do what they can do, which is manage the majority of patients with asthma and COPD.
Thank you so much. We have another question in the chat. There's two that I'm going to wrap into one. We have time to address those. It's about the engagement of industry, principally the pharmaceutical companies that make the inhaled medicines and pharmacies, which are often private in low and middle income countries. Would anyone like to comment on engagement of industry? There's just a handful of companies that make these inhaled medicines and private pharmacy networks.
So Leith, perhaps I'll make a start, shall I?
Thank you, David.
So I think there has to be a partnership with industry in achieving the goals of improving access to therapy. But at the same time, it has to be seen that this is for the benefit of patients and it has to be negotiated through government. So I think industry has a huge role in raising awareness. There's no point providing the inhalers in these countries if nobody knows how to use them, and industry has a long record of education, of supporting educational initiatives. So I think it has to be a partnership, but it has to be clear that this isn't just a marketing exercise to grow the markets for the pharmaceutical industry. This is about getting the drugs to the patients who need them, and the negotiation of the contracts for that has to be at a sort of governmental level. But I think it has to be a partnership. I think the point about pharmacists is very important, and it's not just pharmacists. Many countries that we're talking about don't have established primary care in the way that we would accept in Europe or in North America. So using any contact with somebody who has an interest in health, whether it's a pharmacist, a primary healthcare worker, to recognize that many of these countries, a cough will be due to an infectious disease, but actually there are other causes as well. And having simple diagnostic tools has been mentioned by Alvaro, and I think that's where the PEN guidelines from WHO will be very useful as to how you move forward to separate out things like TB from actually underlying COPD as the main problem. So I think using the whole healthcare community is essential for this. It's not just doctors and nurses or pharmacists, but everybody that could be involved in improving diagnosis and then referral for treatment.
Thank you very much, Professor Howard.
Can I just add one thing here? I think that there's an important, the involvement of industry is often sort of a two-edged sword. People are wary about conflicts of interest and about in whose interests are the actions being taken, as David just said. There is one very important thing about the medicines that the inhaled medicines that we're talking about. They're virtually all off patent, which means that they're being manufactured by multiple different companies. There's not one company that has a patent on the product. Many companies are manufacturing the product, and at least in theory, they can compete on price as well. And so that, I think, makes the engagement with industry in some ways more straightforward, but there are many partners that we need to engage with. It also means that the cost of these medicines and the margins that manufacturers make are much smaller than they are on newer patented medications. But these medications have been around for decades, and so they're not owned by any one company.
Thank you very much. And there's a couple of comments about respiratory therapists in this category of clinicians that is a feature of the US system and other high-income country systems. How you feel about cadres of respiratory therapists as part of the solution in low and middle-income countries? Would anyone like to comment on that?
Well, our main focus is on access to the drugs and prescription of the drugs. That does require patients to be shown how to use inhaled medicines. In many countries, that can be done by the pharmacist or by the person who prescribes or dispenses the medication. Inhaled respiratory therapists are a particular, as you mentioned, have an important role in the US healthcare system, and it's my understanding that it involves delivery of hospital-based care, often for patients, and that is important, but it's not the main focus, I suppose it's fair to say, of what we're doing. I don't know whether somebody else on the panel wants to come in on that question.
Professor Cruz.
Alvaro.
Well, the program that I mentioned with severe asthma clinics, severe asthma ethicals, the definition at that time, which were very uncontrolled asthma, leading people to emergencies. We set up a clinic with a doctor, a specialist, and nurses and physiotherapists. So this team of pharmacists, so this teamwork was behind the success we had, individually reducing hospitalizations and emergency room visits by over 90% of the patients with the combination of the inhaler, the good team work. So I think we should work as a team, and quite often the doctors are not enough to provide the best educational, teaching people how to use the inhalers, using device that substitutes spirometry like the peak flow meters to try to make the diagnosis, and providing emergency care, not at a secondary care level, but at primary care level, providing medication by inhalation to treat attacks. So I think any healthcare professional may be part of this team, and certainly the respiratory therapists, at least in Brazil, they've been very, very important in our team.
Thank you for that. Okay, let's move to our next speaker. Before we do, there are a couple of comments about translations of the first campaign material in the chat. They will be coming in French and Spanish, and now Portuguese, thanks to the intervention in the chat of Angela Honda. That's why we love Zoom chats. We get great ideas. So it will be available in 3 languages, and stay tuned for the FIRB's website when they will be coming in coming weeks. Now we're going to return to the program. We're going to zoom out from inhaled medicines and chronic respiratory disease and talk to the NCD Policy Lab. We have Marina Giacchino representing the lab. You're going to learn what it is and some of the interesting work they're doing in access to medicines for diabetes, and maybe some lessons we can learn as we try and turn all of this work into multi-country programs, which is our end goal. So Marina, over to you.
Yes, thank you very much. I'm just going to share my screen. Can you all see my screen?
Yes.
Okay, so good day, everyone. Thank you, Anget, so much, Leith, for this great opportunity for us to present the work of the NCD Policy Lab. So for those who have never heard about us, we are rather a new project, which is funded by the Swiss Agency for Development and Cooperation, and we are embedded into the University of Geneva and Geneva University Hospitals. So I will try to provide you with an overview of what we are doing within the NCD Policy Lab, which is focusing mostly on diabetes for now, and see how potentially this could be used as a lessons for COPD. Okay, so our team lead is Professor David Béran, who has been working on diabetes and access to insulin for quite some time now, starting with in-country health system assessment, looking at diabetes management and insulin throughout countries such as Mozambique, Mali, Zambia, Kyrgyzstan, and others. The results of these assessments highlighted the need for a better understanding of the global insulin market. And this work was then continued through the Access study with the support of Health Action International, where focus started on mapping the global insulin market from different angles, including trade issues, intellectual property, and pricing. And in phase 2, the aim was to figure out how to use the global market insights to support change to the pilot countries. And at the same time, refine the global perspective through those national experiences. So then in 2019, and thanks to all this previous expertise, we were then approached by the Swiss Agency for Development and Cooperation, saying they would like to do something on access and what can be done. So what we did was a mapping of the existing gaps, and I'll come back to that in the next slide, but just to finalize the different chapter of the history since 2021, the Access study then started to integrate the elements of self-monitoring and diagnostics as well, working in close collaboration with FIND. And in 2023, that's when we really started the NCD Policy Lab, focusing on translating science and all this research that we had done into policy. So this is just to show you that it's a lengthy process. It requires a deep understanding of national context to inform both global and national reflections, and also timing. In 2021, we had a World Health Assembly resolution on strengthening prevention and control of diabetes, as well as the launch of the Global Diabetes Compact, where all this information and experience has been used as well. So if we go back to the mapping, so we were asked by the SDC to identify key initiatives and gaps that need to be addressed to improve access to medicines. And to do this, we used the WHO framework and looked across different areas. In terms of research, development, and innovation, particularly around diagnostic technologies, that's where FIND is already active and doing important work. For the regulatory side, especially related to NCDs, support has been given to our national regulatory agency, so Swissmedic, to strengthen that area. And when it comes to procurement and supply, both at a global and national level, there are already pool procurement mechanism in place through various organizations. And the focus here was more on reinforcing and supporting those existing efforts. And around prescribing, dispensing, and use, so the SDC is already involved through bilateral support to countries, helping strengthen health system to better deliver NCD care. So in the end, the real gap identified was more in terms of translating all these competences and knowledge into action. So, but without losing sight of the importance of the technical know-how. The results of the mapping really help shape the start of this new project, so which aims to improve access to affordable quality assured medicine and technologies using diabetes as a tracer condition. To do this, we're working with 3 long-term partners, so Santé Diabète in Mali, Health Policy Analysis Center in Kyrgyzstan, and Chronicus in Peru. The project focuses on 3 main outcomes, so we have 2 more technical, one on strengthening regulatory capacity, and one more about exploring pool procurement initiatives. And then the last one more on promoting evidence-based policies by bridging the gap between science and policy. So working on access to medicine requires many different types of activities, I would say. Sometimes it's simply about bringing experts together in a room for 3 days, even if they speak in highly technical terms that many of us may not fully understand them. But this is what we try to do, is combining deep technical expertise with ongoing knowledge generation and then trying to translate that science into policy relevant action. So for the regulatory elements, one example is our exercise of identifying and mapping the insulin producers to simply understand better the manufacturer's landscape. And for the outcome 2, so on procurement, another example is the document that we have developed about where countries can purchase diabetes medicines and medical devices by providing information transparently on where and what existing mechanisms are in place and can be used, how to benefit from this mechanism, and the indicative price and contact details of the person in charge when the information was available. And you can find all this information and the documents on our website as well. So for the outcome 3, our approach rests on 3 key pillars. We have research, capacity development, and what we refer to as service à la cité, which can also be understood as societal engagement. And linked to this, on this slide, you can see 3 local examples of events that the NCD Policy Lab co-organized with long-standing partners. So in Kyrgyzstan, last year, we had a roundtable with ministries, universities, civil society, and others to present national, but as well global data to policymakers, to show all the existing challenges, but as well to discuss how to bridge the gap and use research findings and evidence in decision-making. And one result here was already that all agreed that there is a need to improve evidence-based decision-making. And also they signed a meeting resolution, and now they are planning another meeting in a couple of months to develop jointly this mechanism. Another big event took place this year in Peru on strategies to improve access to medicine and health technologies in diabetes, discussing with the Ministry of Health, PAHO, and other key policymakers about regional regulatory issues, supply, and self-monitoring challenges. And here as well, one result was already the fact of gathering all these people together. And now, along with the access study, we will have as a next step a regional meeting with not only ministries from Peru, but from many different Latin American countries to exchange on these similar issues. And finally, we have an example in Geneva where, with the support of the Geneva Science Policy Interface and the participation of WHO, we organized a multi-stakeholder workshop. So it brought together people from 20 different countries, from diverse backgrounds, for an open forum using the collective intelligence in the room to come up with concrete recommendations on how to improve national and international science policy ecosystem for better diabetes policies. So from this experience, I would say there are several important lessons that we can take away. Engaging the right stakeholders is crucial, both globally and locally. So it's essential to really understand the local context, the importance of local research, and knowing the local players. Strong local partnership really makes a big difference. For example, our collaboration with partners is over 10 to 15 years, and they really have built strong local ownership. This is why ministry officials or representatives from organizations like PAHO are actually willing as well to stay engaged for entire days discussing these important issues. Then we have a mix of activities which is needed. As we saw, the technical expertise and knowledge generation is strongly needed, but also the translation of this through different formats. And last but not least, it's a lengthy process. So it requires time and also good timing. And we need to consider not only how research informs policy, but also about continuously monitoring how policies are implemented and evolve. So now I hope this was useful and maybe could lead a potential way for the COPD agenda. Thank you very much, and let me know if you have any questions.
Thank you very much, Marina. Please put any questions or comments into the chat for Marina, and we'll pick them up. But we're going to transition to our next speaker now, and it's Leslie Ray-Ferrat, the new president of the NCD Alliance. So this inhaled medicines agenda we're talking about is a subset of a bigger issue, access to medicines, which itself is a subset of a bigger issue, which is NCD prevention, diagnosis, and treatment. And Leslie's going to tell us about the big picture and how we all march together in alignment in this pivotal year for NCD action. Leslie, over to you.
Thanks so much, Leith. I'm going to try and address what you just said there. But good morning, everyone, and thank you to FEARS for organizing this event. And on behalf of NCDA, we're very happy to co-host it and also just kind of put a spotlight on such an important topic, access to inhaled medicines, which is part of a much broader debate on access to NCD medicines and should be absolutely at the heart of the deliberations as we head towards the UN high-level meeting on NCDs. So I've just got a few slides to go through here. So for those of you who aren't super familiar with the NCD Alliance, I'll just give a quick overview. It was founded in 2009, and it's a global civil society network based in Geneva. And it's got since 2009, over 500 members. And it's continuing to grow, and they represent all of the different risk factors and diseases. Its overall mission is to unite civil society to drive action on NCDs with a focus on achieving the global targets, which we'll talk a little bit about today. The impact goals for 2026, kind of the 4 areas that the organization is working on is prevention, care, financing, and community engagement. So all of the work that we do is surrounded around those 4 impact goals. 2025, extremely important year. So for those of you who aren't familiar with it, or for those of you who are constantly hearing it all the time, you do know that we are now moving towards the 4th high-level meeting on NCDs and mental health, which will take place in September of this year. High-level meetings are kind of they're a global multilateral process to address global issues. And why I think they matter is because it serves to elevate health from this kind of technical to political realm at the highest political level during the sidelines of the UN General Assembly. And the process itself is just as important as the outcome, because if you're thinking about it and you've been involved in this process, you've seen now how NCDs has kind of been in the spotlight and the forefront of the attention for the last 12 months and will continue on up until the high-level meeting in September and then even after that. So it's a really big opportunity for us as a community to focus our attention on this, to reiterate the commitments, review progress, and then collectively agree the way forward, and really kind of galvanizes consensus on international cooperation and national commitment. So it really is a really key, important moment. And in 2025, I think it's even more important as we're facing a massive implementation deficit in terms of NCDs, knowing that we are globally off track to achieve the global NCD targets. So it really is an important year where we can kind of look at these targets, including the global NCD monitoring framework, which are set to be updated and really serve as a stepping stone towards the 2050 agenda. So this is a really important year for us. And you'll also see that, we've had a meeting in 2011, it was 3 years, and then it was 4 years, and now it's been 7 years. So I think it's really important for us to kind of galvanize and bring that attention back up. So as I mentioned, we cover at NCDA a wide array of NCDs. So what we've been trying to do within our advocacy priorities for the high-level meeting is really focus on the areas that are cross-cutting and relative for the entire NCD community. So for those of you who aren't familiar with this, for the UN high-level meeting this year, we have 5 major advocacy priorities, which can be tailored to specific risk factors and diseases as well. So like I said, we're just trying to look at the cross-cutting nature of them. So I'm just going to read through them quickly. Accelerant implementation. So we're really pushing that we need to move from just recommendations to actual implementation at the national level. Breaking down silos, and we need to do this, we need to achieve more together. So there are many opportunities to use existing systems to get more with less. Mobilize investment. As we all know, NCDs are not receiving the funding that they need. So we should be looking at mobilizing investment at the global level, but also at the national level through domestic resource mobilization. Deliver accountability and engage communities. So delivering accountability, ensuring that we're tracking and measuring and fulfilling all the commitments on NCD prevention and care in the lead up to 2025, but also 2030 and beyond, as we are likely to not meet the targets that we set in 2030 as well. And then in terms of engaging communities, really putting people at the heart of the NCD response, engaging civil society, communities, and most importantly, people living with NCDs in the decision-making and implementation. So since NCD was set up in 2009, one of our primary focuses has been on responding to the major challenge of access to NCD care, primarily in low and middle income countries. And a key aspect of NCD care is equitable access to NCD medicines, diagnostics, and medical devices. So one of the documents that I went on to highlight is on access to medicines, diagnostics, and health technologies. So FEARS has been a part of developing this document along with many other organizations. We really spotlight access issues for respiratory conditions. And within the brief itself, it calls on existing member state commitments on access to be implemented. So there's just kind of a snapshot here of the 5 key asks. And it highlights the many commitments, resolutions, and political declarations made by member states on this topic of access to medicines, and makes 5 recommendations to support countries in making meaningful progress towards this goal and accelerating action on existing commitments. So you can see these 5 here: facilitate the transfer of technology skills and know-how, develop and implement pricing policies, streamline regulatory processes, build the capacity, and ensure the rational selection of procurement of NCD medicines. The process for developing this brief has fed into our recommendations on the 0 draft of the 2025 political declaration, and which will be the key outcome document of the high-level meeting. So on the next slide, I'll just show some of that there. We have made recommendations. NCD has made recommendations on the entire 0 draft of the political declaration, but here I'm just kind of highlighting some of the recommendations that we're making in terms of access to medicines. So on various paragraphs, we've tried to strengthen the language surrounding access to medicines and health technologies for NCDs and mental health conditions. On CRD specifically, NCD has included recommendations from FEARS and GOLD to add language around access to inhaled medicines, adding specific language around the needed products that will support actual asthma and COPD patient needs, and also reinforce the case for access to these products. So these are kind of just some of the recommendations that we've been making there. And so looking ahead to the 2025 high-level meeting, it is absolutely clear that we're going to need to work on harnessing collective power, strategies, and influence to ensure that the high-level meeting moves the needle on NCDs more broadly. So on this slide here, I'm showing just a few this one, and the next slide will show a few opportunities on how you can engage and how we can all speak with a common voice at the 4th high-level meeting. So on this QR code, I'll leave it up for a couple seconds so everyone can hopefully scan it while you can see my screen. So this is NCDA's proposed text for the 4th high-level meeting political declaration. It has been developed and in consultation with numerous stakeholders, including FEARS and GOLD, and includes recommendations on including language on access to inhaled medicines, as I showed you before, but it also includes strengthening language around a lot of other kind of key cross-cutting issues for NCDs more broadly. So we're really encouraging folks to use this language and this proposed text for the political declaration. And then lastly, one more QR code here. So this is the call to lead. This call to lead was launched on May, it was an open letter launched on May 2nd at the multi-stakeholder hearing. It was really great to see at the multi-stakeholder hearing on NCDs how many organizations were aligning themselves with this call to lead. So far, we have 520 organizations representing 2.4 million voices through 115 countries. So if you haven't already signed up, I would encourage all of you to sign on an individual basis and also on an organizational basis. It's a very brief call to lead, a call to action to governments, outlining 3 key actions that all governments must take to accelerate action on NCDs. It's a very easy step. Also encouraging folks to continue to use these 3 kind of action areas that we're calling on governments to lead on in your speaking points and in your discussions with member states and partners. So I will stop there and hand it back to you, Leith, and hopefully that was a very brief overview of what we're doing and how to engage.
Brilliant.
Thank you.
And please take advantage of all those links, everybody here. There's the NCD Alliance is your go-to place to figure out what's going on and to join the right platforms and organizations and events. So thank you for that. To our final speaker, we are very happy to turn to Dr. Jose Luis Castro. Many of you know him already. If you don't, he's the WHO Director General's Special Envoy for Chronic Respiratory Diseases. And I have to restate the title of Dr. Castro's presentation because it truly says it all. What will it take to get Cinderella to the ball, putting chronic respiratory diseases on the map? Dr. Castro, over to you.
Thank you very much, Leith, and hello everyone, and welcome to this webinar. Thank you for the opportunity to close today's discussion. You know, as I listened to all of your presentation, you couldn't articulate, more powerfully and clearly the message that we want the world to hear about the need for access to inhaled medicines. And you may have noticed that, as Leith mentioned, this session has an unusual title, but I think it is all too fitting because chronic respiratory diseases have long been treated like Cinderella, overlooked, overfunded, and kept far from the spotlight while everyone else gets to go to the ball. But we are changing that. And what it will take is exactly what we are already started to doing together and what has been described by some of the speakers here, making the case that these diseases matter, not just medically, but socially, economically, and politically. Our progress getting CRD, especially asthma and COPD, on the policy agenda where they belong starts with visibility. If CRDs remain invisible in the public imagination, they will remain invisible in the policy priorities. And that's as simple as that. That's why we can be shy. That's why we have to make noise. That's why we've launched a series of initiatives designed to change how people see these diseases and who sees them. The first is a media engagement. We've begun working we began training health journalists around the world to report on CRDs with the urgency and the depth that they deserve. In April, we convened 15 leading journalists in Mexico City for the first of its kind training. Our next session will be in Malaysia. And already these efforts have led to more than a dozen articles and radio programs compared to just one story in the previous year. And by the way, what was that story? It was an obituary. When we can do and must do better than that, we have to tell these stories before it is too late, not only to honor the victims. Our mission should be to prevent those obituaries from being written, at least for a long, long time. The second step is political engagement, and we are working to build a caucus of parliamentarians committed to advancing CRD. These champions will help ensure this issue stays on the political agenda, not just during the moments of crisis or commemoration, but year-round across governments. Those political declarations that are made in New York need to have the governments being held accountable by civil society, by parliamentarians, by the press. And that's why this work is so important. And the third is the public engagement. We are now commissioning the development of a public strategy to shift the face of CRDs through awareness campaigns, storytelling, and creative outreach. I hope to have more to share soon as we move forward together with this work. But that's not all. We are also forging alliances beyond health, and that includes outreach to sectors like finance, labor, education, and housing, because we know that the conditions that shape lung health don't begin or end in the clinic. And meanwhile, we are also working closely with climate and environmental organizations to address shared drivers, but of both planetary and pulmonary health. We are elevating patients' voices, and we're organizing more effectively. And we are pushing this agenda in places that matter. The last several months have been a whirlwind. Since September, we've worked closely with the United Nations Interagency Task Force for Non-Communicable Diseases, presenting to over 40 agencies. We've launched outreach to the G7 and G20 countries. And this summer we'll support two major events, one in China and one in Brazil, focused on CRDs. As mentioned by Leslie and other colleagues in September, there will be the UN high-level meeting in New York. And at this place and the sidelines of the UN high-level meeting, there will be not one, but two side events dedicated to CRDs. One co-hosted by Denmark, which will hold the EU presidency, and the other one by the European Respiratory Society, WHO, and the UN Interagency Task Force on NCDs. This is what it looks like to get Cinderella to the ball. We can't just hope to be invited. We have to show up and knock on the door with allies, with evidence, and with a plan. But let me end with a caution. Visibility is not victory. We have made progress, but this is still a highly competitive field. Other diseases command more attention, more resources, more headlines. The world is facing economic crisis and wars that also command the attention of presidents and governments. And we cannot let chronic respiratory diseases stay in the shadows. Not when we know that the scale of the suffering, and not when we know how much a difference that we can make. So let's keep showing up, and let's keep raising our voices, and let's keep fighting to make sure that the next time that someone asks, what will it take to get Cinderella to the ball? We can say, she's already dancing. Thank you very much.
Oh, fantastic. Thank you, Dr. Castro, for those extraordinary remarks and for your leadership. And I want to acknowledge also the strong support of the WHO team. I think Sarah Rylance is with us today, but there's a fantastic WHO team that have really supported this inhaled medicines campaign as part of this broader effort on chronic respiratory diseases. So thank you for your leadership. So that concludes our speakers for today. I just want to end with a few remarks and we can let you go home. So I want to thank all of our speakers and our co-hosts, FERS, the NCD Alliance, the NCD Policy Lab, and the World Health Organization. To you, our audience, we have some very specific asks. 3. The first, we want you to share the FERS campaign materials. They're all on the FERS website. Read them, look at them, learn about them, and share them with your networks, internal and external. We want you to support our proposed language to the UN Political Declaration for the high-level meeting. Both Professor Zah and Leslie showed you the updates to the language to get it exactly right so it reflects best practices in clinical care. Please support that language. And third, we would love you to become an advocate for access to inhaled medicines within your own organizations and broadly. This is a neglected area, but as we said, it's something that affects more than 600 million adults and children across the world. Finally, a special thank you to the members of the FIRS Working Group on Access to Inhaled Medicines for COPD and asthma. You've heard from 3 of them today, Professors David Halpin, Guy Marks, and Heather Czar. They are true champions for this issue, and it wouldn't be happening without their leadership and elevating their voices. But you've also heard about a 4th member several times today, Professor Eric Bateman, who is no longer with us. He passed earlier this year, but he was deeply committed to increasing access to inhaled medicines, no matter where a person lives. May our efforts together with all of you do justice to his vision. Thank you very much for joining us. The recording will be available later on YouTube and all of the slides on the FIRS website. Thanks.